Hi, this is Nader Moinfar, and this video is a surgery for a patient that has a condition known as proliferative diabetic retinopathy. You may recall that diabetic retinopathy can occur with different levels of involvement of the eye. One of the more aggressive forms is a state known as proliferative diabetic retinopathy, and I'll address that with a little bit more detail in a few moments. What's happening now is I'm placing the first of 3 cannulas into the eye. This is a standard configuration for a vitrectomy. The silicone tube that was just attached is called an infusion line, and I'm securing it into the cannula. The other end of the cannula is attached to a bottle of saline, and there's a machine that basically monitors the pressure of the fluid going into the eye. Many machines, including the one that you will see being used here, can also be controlled by the surgeon on the foot pedal. What I'm doing here is placing the marking for the insertion of the second cannula. Now these are all what are called self-sealing cannulas. Vitrectomies historically used to be used with much larger instruments, and this is what's called a 25 gauge. There's also a slightly smaller platform known as 27 gauge. They're not used that often. I have personally used them, but they're not that frequent yet. And that last cannula was the third and final cannula through which the instruments are inserted and removed into the eye. Now in a few moments you'll see a round looking lens. That's the lens that's going to be put into place. This is a non-contact wide field lens. One of the challenges that retina specialists have is trying to ensure the best view possible, both for the patient safety of the patient and for the ease of the surgery. Now at this point the light on the microscope has been turned off. To the right is one of the instruments that goes into the cannula. That's a light pipe, and on your left you'll see shortly another instrument come in, and that's called the vitrector. Both of these instruments are connected to the machine that stands next to the patient. Now the patient is typically awake but mildly sedated during the procedure. I am sitting at the head of the bed, and to one side of the patient is the anesthesiologist, and to the other side is the surgical scrub nurse. Now this video has not been edited so that you have an appreciation of the true time frame and steps involved. So the procedure in this video takes about 30 minutes, and that's about typical for vitrectomies. This patient also happens to have a traction retinal detachment, which adds about an extra 10 minutes to the surgery. So most of these cases take about 30 minutes, and again this has been unedited, so sometimes there are pauses as we adjust our microscope, adjust our lens, and sometimes just pause to recheck the configuration of our instruments and the parameters on our vitrectomy machine. So basically what I'm doing here is performing a core vitrectomy, which is removing the central vitreous. As you may recall from previous videos, the vitreous is generally the clear jelly that occupies the inside of the eye. We're born with it, and basically it just changes over age, and in most cases it really can be left alone. But in some cases, whether it be a retinal detachment or complications from diabetes, the vitrectomy is a procedure used to remove that vitreous gel. And so what I'm doing here is now trying to create what's called a posterior vitreous detachment. You may read on my website, we've talked about a PVD, or a posterior vitreous detachment, as a frequent cause of flashes and floaters. Most diabetics at this stage do not have a PVD, and it's very important that one be mechanically induced by the surgeon. Failure to do so is a frequent cause of rebleeding after surgery and or persistent or recurrent retinal detachment, and it can be very tenacious and somewhat challenging in diabetics, but with experience and some good luck it usually is feasible. Quite often, as you'll see in this case as well, it's helpful to use the assistance of various dyes or chemicals to help stain and identify the vitreous. You'll see in a few moments that I'll be injecting some cortisone inside the eye that allows me to better identify the vitreous and to identify the strong areas of adhesion between the jelly of the eye and the retina. Now, you may have noticed at the beginning of the case that the patient had a little hemorrhage on the outside of the eye. That's called a subconjunctival hemorrhage, and the reason why is because she received an injection of a medicine a day or two before surgery, a medicine called Avastin, which many of us use preoperatively to help reduce the probability of bleeding during surgery. And quite often patients will get a little hemorrhage from the injection site. So again, here I'm trying to confirm, and you may be able to have seen the induction of the vitreous detachment, at least on one section of the retina. It came off quite nicely, and I'll just be working on that for a few minutes, trying to get it all off. During this time, the patient is awake and again quite comfortable. So I just injected a white material inside the eye. There's different things, different kinds of steroids that one can use. This is one called Triessence, and it's approved for aiding visualization during vitrectomy surgery, and it basically sticks to the vitreous, and so it allows me to better see what I would otherwise possibly miss, and it also allows me to complete the posterior vitreous detachment. Again, we don't want to leave anything behind. And once the posterior vitreous detachment has been induced, then the vitrectomy actually proceeds rather quickly. This patient, as you may have noticed at the beginning, has her lens in place. In fact, like many diabetics, she already has a fairly significant cataract. Most of us with a fair amount of experience can work around the cataract, but it does present certain challenges during a vitrectomy. One of the risks is always in a patient with a lens that the instruments that go inside and outside of the eye can actually hit the lens and cause a traumatic cataract. So we have to be very careful in these cases to make sure of our spatial orientation, and that we don't move the move the instruments too far anterior and risk damaging the lens. Fortunately, where I operate, we have very experienced scrub nurses that can assist us with indenting the eye during surgery and help us kind of see the hidden areas that would otherwise be very difficult to access. Now at this point, I think I have most of the posterior vitreous already detached, and I'm just working on removing the rest of the vitreous gel. At this point the case is about 1/3 completed, and we're just making sure that maybe remove as much vitreous as possible. Now with these kind of surgeries, they're typically done in the outpatient setting. It can be either a freestanding surgery center, as in this case, or it could be a ambulatory surgery center affiliated or attached to the hospital. Essentially, the configurations are the same. The patients will be given some sedation through their vein, and an anesthetic is injected around the eye. Typically, it's called a retrobulbar anesthetic, where a needle is passed, usually, but not always, along the bottom part of the eye, just above the bone, and it's gently passed into the posterior portion of the orbit. And if done correctly, very good anesthesia is achieved. That means that there's no pain during the surgery, and also very good akinesia, which means that the eye does not move during surgery. One of the frequent questions that patients ask before surgery is, "Are you taking my eyeball out?" No, we don't do that. The eye stays exactly where it is, and we just make sure that it's comfortable and doesn't move during surgery. So what I'm doing now is I'm trying to get as far peripherally to the vitreous as possible, taking great care to not hit the lens and to also not inadvertently hit the retina. So once the vitrectomy is completed, that's pretty much the second stage. The first stage is to get the cannulas into the eye and make sure that the patient's comfortable. Second stage is to complete the vitrectomy, which involves removal of the gel of the eye completely and the vitreous detachment. And then the third stage is to apply laser treatment. Now, laser treatment can be done with fluid inside the eye, or it can be done with air inside the eye. There are pros and cons to each. I generally prefer to use air for a couple of reasons. One is that it creates what's called a minified view. And basically what that means is one can see farther out to the retinal periphery, allowing for more extensive laser treatment. But it also helps control any bleeding during the course of the surgery. And I generally tend to leave air inside the eye at the conclusion of the case. Many of us do that, although we're probably in a minority. And again, the reason for that is that there's some evidence that may reduce the risk of leakage from the wounds postoperatively. Now what I'm doing here is switching instruments, or sometimes switching hands. I'm right hand dominant, so sometimes to get to the other side I switch hands. So I've switched hands here, and now what I have on the left side is the light pipe and the vitrector on the other side. So I just basically switch hands so I can access the opposite side more safely. Now getting back to the wounds. Now these wounds are typically not sutured. These are, if constructed correctly, these wounds are self-sealing, and so sutures are not used typically. And leaving an air bubble inside the eye, there's some evidence that it may help reduce the probability of any leakage. So sutures are not used. Now sometimes if the surgery is particularly long, or there's a lot of manipulation of the eye during surgery, then the incision into the eye, also called a sclerotomy, may become a little bit more gaping than we would like it to be, and a simple absorbable suture can be passed. There are different types of absorbable suture, but typically they absorb over the course of about 10 to 12 days. So patients may sometimes feel like there's a little scratchy or foreign body feeling from the suture, but again, it absorbs on its own. But in most cases, sutures are not needed. It's actually quite unusual, especially with the 25 gauge system that you see being used here. Now again, I'm switching some instruments here, maybe just switching from my left hand to the right hand. And now you can see the light pipe is coming out of the right and the vitrector is back on the left. So again, what I'm trying to do here now is make sure that all the traction off the retinal detachment is being released. Now typically, getting back to the configuration in the operating room, there's a screen that projects what I see for the benefit of the other personnel in the operating room. Typically there's a scrub nurse that is in sterile clothing who hands the surgeon the instruments, and there's also someone called a circulating nurse, which is a registered nurse that basically prepares any medications that we need during surgery, and also is basically there to hand over equipment from the storage area or the sterile supply. So basically projecting it onto the screen helps keep all parties engaged as to what is going on. So the procedure is a little bit over halfway done at this point, and in a few moments you'll see a couple things being done. One of them is something called a Squirrel Depressor exam, which should be standard procedure. Basically what happens is we use a little instrument called a Squirrel Depressor or a muscle hook to gently indent the eye all the way around to make sure that during the surgery no iatrogenic breaks or tears are created. Iatrogenic basically infers surgeon or provider related. So I just want to make sure that I haven't created any retinal tears during the surgery. So we do a Squirrel Depressor examination under the microscope. Now here what I'm doing is shaving the vitreous space. I'm very close to the retina, and you can sometimes see it kind of fluttering there going into the port. And what we do is, as I alluded to before, there's a foot pedal, and what we do is we adjust the parameters, the vacuum setting, so that there's not too much traction, because we're very, very close to the retina here, but we're just shaving the vitreous space and kind of working around the cataract as best as we can. Now the red light that you see is coming from the laser probe that I just inserted. So what I'm going to be doing now is applying laser treatment for two purposes. One is to basically control the diabetic retinopathy, and I also use the laser to diathermize, or basically apply heat to any areas that are bleeding. There's different ways of trying to control bleeding. Sometimes if it's very mild, one can just increase the pressure that the machine is applying to the fluid. One can also use something called endodiathermy, which is basically like a hot probe, but that sometimes can cause more problems. And sometimes you can just do laser treatment to the areas that are bleeding using a pretty long duration. But what I'm doing here now, with every flash of that you see here, the green light, is actually applying a spot of laser. And again, there's another foot pedal connected to the machine. So the surgeon basically has 3 foot pedals on the floor. One of them is to control the microscope, the other one is to control the vitrectomy machine, and the third is to control the laser. And some places there may be a 4th pedal that controls the lens. It's called an inverter, and basically with the type of wide field lens that we have to basically invert it, otherwise we get an upside down and left side right image. So there's always 3 and sometimes 4 foot pedals, and of course both hands are working at the same time. So basically what I'm doing here is applying laser to the retinal periphery, and this kind of takes just a few minutes. Now typically the bright flash from the laser theoretically can cause damage if one looks at it directly. It's not so much a concern for the staff that I referred to before, the anesthetist or the circulating nurse or the scrub nurse. It's more of a concern to the surgeon actually in this case, because I'm looking directly into the laser. So we have a filter that's put into place just before the laser starts to help protect my eyes. Now laser can be applied just as you see here with a laser probe inside the eye. Laser can also be applied what's called an indirect method, which is where the surgeon puts on a headlamp similar to what you may see being used in the clinic, and the laser is delivered directly from the machine through the headlamp to the back of the eye. But now with the optics and the visualization systems that we have, we can pretty much get all the laser done just internally and not have to spend extra time putting on different equipment or taking it off. So the procedure is probably in its last 25%. There's about 10 minutes left, and basically that's going to be consumed with completing the laser, checking the retinal periphery for any retinal tears or breaks, and then in reverse order removing the cannulas and putting a little bit of pressure on the wounds to make sure that they're nicely opposed and that there's no leakage. And we also do what's called an air fluid exchange, as I had alluded to before. Then we also administer some antibiotics onto the eye, and then we put a patch and shield. Now once we've confirmed that everything that we used during surgery has been accounted for and nothing has been left behind, the patient is, the drapes are taken off the patient and the patient is transported directly to the recovery room, and they usually get something to drink and eat within a few minutes. And in most cases, just with the local anesthesia, patients typically put their clothes on and get ready to go home in about 20 or 25 minutes. And they're instructed not to drive, of course, that day because they've gotten some sedation, and to avoid alcohol. Now, typically patients are seen the next day, and if the vision in the other eye is good and the patient is comfortable, they're certainly legal to drive, and they can drive themselves. It can be sometimes difficult if they wear glasses because the patch and shield may make it a little bit bulky for them, and the glasses may not sit correctly. So it's better to have somebody at least the next day after surgery to bring you to the clinic, but if resources are not available, then it's certainly not unreasonable to drive oneself. On the first postoperative day, the patch and shield are removed from the eye, and typically the vision is actually worse on the first day. So that's something that I always inform my patients, and that can either be because there's an air bubble in the eye, or there can be some little bit of blood that oozes overnight and can be impeding the vision. And those are usually quite self-limiting and not a big deal. So what I've done here is I've switched hands. I've put the laser probe in my other hand, again, to try to access the other side and make sure that I have as much laser as possible. We really don't want to have to do laser in the clinic after surgery, and that's not that common anymore. So I'm just switching hands and applying laser to the other side. Going back to the postoperative care, the patch and shield are removed the next day, and again, typically we're not too alarmed by a decrease in vision. In fact, we expect it. The things that we look for on the first postoperative day, and in fact for maybe the first week or 2 weeks, is to make sure that the eye pressure is normal. Sometimes the eye pressure can be low, but more frequently we're concerned about the eye pressure being too high, especially if a patient has a pre-existing history of glaucoma. And in most cases that's self-limiting, and we just watch it. If it's a little bit higher than the surgeon is comfortable with, then medications can be used to keep the eye pressure down. The other thing that we look for is any signs of infection. Infection, also called endophthalmitis, is actually quite rare after vitrectomy, but we do look for any signs of infection and any signs of inflammation that is kind of out of proportion to what we expect. And then in the next several days to a week or two later, we monitor for normal healing. We want to make sure that there's no retinal tear, there's no retinal detachment, which can happen after any surgery, but particularly vitrectomy surgery. And what I'm doing here now is, you see that little thing that looks like a hockey puck? That's called a muscle hook. And what I'm doing now is that Squirrel Depressor exam part, and you may see at about 12 o'clock kind of a bulge. That's the peripheral retina coming into view. I'm going to try to redirect the light pipe towards that area. And I'm basically kind of walking around the eye. I was at 1 o'clock, now I'm going down to 4 o'clock. And then I'll just kind of rotate all the way around to make sure that I haven't created any breaks or tears or detachment during the surgery. Sometimes patients may feel this part because the instrument sometimes contacts the bone of the orbit or some of the connective tissue. Patients may feel a little bit of pressure, so I give them a heads up, but it's usually nothing that needs to be addressed, more than just some gentle reassurance. So once this portion is completed, I typically exchange the fluid inside the eye with air, and that's what I'm about to do here. And again, the machine called the Vitrector does all that stuff for us. We just we can either switch it on the foot pedal, or we can have our scrub nurse switch the settings on the machine, so that instead of fluid coming into the eye, air comes in, and you'll see an air bubble start to come in just a moment. So that's the air coming in, and while the air is coming in, I am simultaneously evacuating out the fluid. So I've used my foot pedal and switched it to just a vacuum mode and taking fluid out while the eye is filled with air. And so this kind of starts to wrap up the intraocular portion of the surgery. And I try to get a pretty good airfill if I can. The vision will get a little bit foggy before it gets better, and you'll see how it's getting a little bit clearer now. Sometimes we tilt the eye to try to get the glare out of the way. The light pipe can sometimes cause a glare off the air bubble, sort of like shining a flashlight into the mirror. But with experience, you just sort of know what level the air is at and how to see around any glare. So at this point, we're about 28 minutes into the surgery, and we'll be wrapping things up in just a few moments. What you're going to see me do now is that circular thing is going to come out of the way. That's the lens. We don't need that anymore. And one by one, I'll be removing those little blue things, which are the caps to the cannulas. They just come out in one pull, usually. Sometimes a little bit of manipulation, and then I'll use a Q-tip first to put some pressure on it. Then I'll use the end of these heavy forceps to try to reoppose the edges of the wounds just to make sure that there's no leakage. So I'm just going to put a little bit of pressure there. I usually hold that for about 30 seconds or 45 seconds. And then direct my attention to the other two cannulas. And then we give some antibiotic, take off the lead speculum, which is those two metal things that you see at 12 and 6 o'clock that basically keeps the eye open. Then we take the drapes off, put some antibiotic ointment on the eye, and then we put a patch and shield on the eye, and then take the patient to the recovery room. I usually go out and talk to the family, and then I come back and talk to the patient and make sure that they're comfortable, that their vital signs are okay. If they're diabetic, we recheck the sugar. And then I always call the patients, or have somebody from my office call the patient later that evening to make sure that everything is stable before they go to bed, and make sure that there are no issues that we have to address. So basically this is a start to finish in real time, a parsplenic vitrectomy with endolaser for the treatment of proliferative diabetic retinopathy in a patient with a vitreous hemorrhage and traction retinal detachment. I do hope that you found this video to be informative, and more information can be found on my website that you can see on the top left. Thanks very much for watching.